Welcome to the Alain Elkann interviews, an unprecedented window into the minds of some of the most well-known and respected figures of the last 25 years.
Professor Lim, you are a Chinese from Taiwan, right?
Yes, correct.
But you then lived abroad and came to live in England as a young person and went to school in England.
Yes.
You had an undergraduate university from Leicester, and then you had a doctorate from the University College in London. Why did you decide to become, I don't know if I have to say oculist or ophthalmologist or a doctor of the eyes?
That's right. Well, oculist is a very old traditional term. In fact, in the UK, if you are the royal family's ophthalmologist, you still call the king's oculist. So it's a term kind of still used in some way. Only if you can be a royal household oculist as well. But in general, I guess we say ophthalmologist. I think there's always a confusion about ophthalmologists and optometrists. Optometrists are opticians that test glass for glasses. And ophthalmologists can test glasses as well, but we're primarily trained as a doctor. So we can treat diseases and we can do surgery. Although the distinction becomes slightly more blurred because in some US states now, the optician actually allowed to do some procedure and treat condition as well. So you can see the distinction become less and less things. So,
but in order to become an ophthalmologist, let's say, you need to study medicine, right? You're a doctor.
Correct.
And at what moment of your studyings you decided that you wanted to be an ophthalmologist?
During your ophthalmology or your medical training, after your 2 years or 3 years, usually 2 to 3 years of basic science, basic anatomy, physiology studying, you then start to learn about different specialty. And you are supposed to be exposed to every specialty in medicine in that medical school training. Some are short, some are longer, like general medicine is 6 months, but ophthalmology is one of the small specialty. So students usually get exposed to it for 2 weeks during the training. And if that's something that you really want to do, which certainly for me, when I was a student, as a final year medical student, I went to an ophthalmology clinic and saw the patient who had a cataract operation. And the result was incredible. You can see the emotions of the patient when they take the patch off, they can see again. So then I went to the operating theater with the surgeon, and the surgery only took 20 minutes. So that's why really driven me to become an ophthalmologist. I saw that if for such a short operation, you can make such a big difference to somebody's life. And it's incredible. And so having looked at all the other specialty, including cardiac surgery and other things, and including plastic surgery as well, for that matter, but ophthalmology was, in terms of the difference it makes to the patient when they do surgery, such as cataract operation, was so incredible that it got me hooked. So from that day onwards, everything I did as a junior doctors were trying to get into training and become an ophthalmologist.
But becoming an ophthalmology, I mean, you worked in many different prestigious places, including in the United States, where you had a training at the Mayo Clinic, Minnesota, right, which is one of the most famous hospitals in the world. And then later you became a professor of ophthalmology at the King's College in London, right?
Yes.
That's in 2020 you became a professor.
Yeah.
But you are specialized. I mean, what we read in your biographies, you are a specialized surgeon on glaucoma and also on cataract.
Correct.
And not everybody understands, first of all, what is the difference between cataract and glaucoma?
Yeah.
And how can you explain? Because are these the two most common and important diseases in the eyes?
Indeed. These are the two most common blinding disorder in the world. Cataract is probably the most common reversible blinding disorder of the eye in the world. By that, I mean that it can be easily treated. So cataract essentially is a natural lens of the eye. becoming cloudy with age, and also to some extent exposure to sunlight, UV light, and other conditions, systemic conditions such as taking steroids or being ill and sick, can also fasten, exacerbate the formation of cataract. So the natural lens in your eyes, instead of being clear, it becomes cloudy and opaque. So light doesn't go through, so vision becomes blurry. So that is a common problem.
Patients detect cataract by themselves in a way.
Indeed. Patient can sense the cataract formation by seeing things are becoming more and more blurry, despite new glasses, for example, when they corrected for your myopia or long-sightedness, which is hypermetropia. Despite that, they still say, wow, my vision is still blurred. So that's when patients notice cataract causing their
and nowadays, the cataract operation takes place at what stage? And is it very much easier nowadays since you started the job?
That's right. I think cataract operation is currently in the UK one of the most commonly performed operation and is highly successful.
How do you perform it?
Yeah, so the key thing is that the current techniques that you have to make a small cut into the eye and you take the cataract out by using an ultrasound probe. What the ultrasound does is break up the dense cataract into small liquid pieces and suck it out. And then you replace the cataract with a small plastic lens by folding the lens and inject it into the eye. So the wound that you make is only very small, 2 millimeter in size. So that's a tiny, tiny size incision. So that's the modern technique of doing cataract operation. So you can imagine historically, my link to St. Thomas's, where I'm currently a professor and consultant, is that prior to 1950s, nobody would put lens in the eye because there was no plastic lens to replace the natural lens. So before that, patients used to have cataract removed, and they used to have to wear very thick glasses because there was no plastic lens to put inside the eye to replace the lens. So one of my predecessors at St. Thomas's Hospital is called Sir Harold Ridley, who is internationally known because he was the first person to invent a plastic lens in the 1950s to put into a patient's eye to replace the cataract, natural cataract. So his invention, which evolved over the years to a much safer implant lens, is transformative. It changes the world in terms of cataract operation. You can imagine that people come from all over the world. When they visit London, they will come to St. Thomas's, my hospital, to see a little blue plaque of Sir Harold Ridley when he first implanted the cataract plastic lens in the cataract patient. In 1958, I believe, he did that at St. Thomas's Hospital. So that is a very important landmark in terms of modern cataract surgery, where natural lenses are replaced by a cataract lens.
And this operation, it lasts how many minutes? I mean, because your work is a very delicate work, right? You're not operating a big space. You're going into the eye, and probably the eye is the most, there's nothing like the eye in the human bodies, right?
Exactly.
Even in the animals.
Exactly. So everything is much smaller in scale. So what you need to do in terms of cataract operation is that you have to do it under operating microscope, which is magnified in size, so you can see things very clearly. And the surgery itself, if everything's absolutely straightforward, you can even do it under 10 minutes. But most commonly, it's between 10 to 20 minutes. And that's because the modern machinery that we use now are so incredibly powerful and predictable. And it makes the surgery very quick and very safe. In vast majority of patients, it's a very, very successful operation under 20 minutes, you see.
But your specialty, you are renowned for something else. Obviously do cataract, but you are one of the most famous professors on the glaucoma, and you gave lectures, hundreds of lectures around the world. You wrote articles and so on and so forth. What is the difference? What is glaucoma?
Yeah. So Yes, a bit of a recap on cataract surgery. So cataract surgery is very, very common. So virtually every trained ophthalmologist in the UK will learn how to do cataract surgery. So we all perform cataract surgery. So cataract surgery is what we call the bread and butter of our profession. So everybody do that. Beyond cataract surgery, every ophthalmologist tends to specialize in something else as well. So for me, I specialize in glaucoma. That was what my research project was about towards my doctorate degree at UCL. And that was what my fellowship at the Mayo Clinic was about, essentially to learn about glaucoma, special techniques.
What is glaucoma?
Glaucoma is a disease where the pressure inside the eye is too high and it causes damage to the optic nerve. Optic nerve is the structure that sends signal to your brain, from your eye to your brain. So when the pressure becomes too high, it damages the optic nerve. So over time, gradually, patient becomes blind if it's untreated. So the pressure causing the optic nerve damage, leading to blindness.
This kind of pressure is linked to the blood pressure?
Not really. No. I mean, there's some association between the two, but they are not real direct link to that.
Because
so they are very specific.
High blood pressure mostly is cured with medicine, right? You take pills and the blood pressure goes down until you find a proper...
Yeah, that is right. And in some way, most glaucoma can be treated with medication as well, with drops. Obviously, you turn the medication into a drops to treat glaucoma. The principle is similar to treating blood pressure. You somehow get the eye to produce less liquid or aqueous, so the pressure becomes lower. But the eye also have other specific channel that can drain the fluid out of the eye. So some of the medications are designed to encourage the fluid to drain out of the eye when the pressure is high. So by doing that, you are bringing down a very dangerously high level of pressure, intraocular pressure, to a more sort of safety level. So patient's optic nerve doesn't get damage over time. So the principle is the same, is to bring the pressure down to a safe level. And majority of it in glaucoma can be treated with medication.
But blood pressure and eventually glaucoma can be high at any age, no?
Indeed,
I mean, you said that cataract was mostly a disease of people getting old, right?
Yes.
Glaucoma is different, right?
Well, in some way, isn't either. There is also mostly an aging disease. So if you are older, one is more likely to get glaucoma. That is because the channel within the eye that drain aqueous out of the eye, as you get older, it can become blocked. They don't drain very well. And that doesn't usually happen in a young patient, except for exceptional genetic condition. Usually, as you get older, the channel or the drain becomes blocked. And because they are blocked, the aqueous cannot drain out, and the pressure in the eye started building up. So the older you are, the more likely one is to develop glaucoma. So it is an aging disease as well.
But how do you detect glaucoma? You explained before how one detects cataract, but what are the symptoms of glaucoma?
That is where the problem lies. Glaucoma is a slowly progressive disease. It's largely asymptomatic. So patients don't feel it at all. So when the pressure goes up higher than normal by about 20, 30, 50%, patients don't feel any pain. Patients don't sense any problem at all because the damage is gradual, they don't notice it until they went to see an optician. Or if their one eye is very damaged, they cover one eye and they suddenly say, oh, wow, I can't see very well out of one eye, but the other eye is absolutely very clear. So it is a disease that can be undetected. So this is why we encourage people that once you reach age of 40, you should see an optician, because an optician will do extra tests for you that can potentially identify glaucoma, such as measuring the pressure in the eye, looking at the optic nerve to see whether they are damaged, and then doing extra tests like visual field tests or scanning of your optic nerve to see whether there's any damage that causing area that you are not seeing very well. So it is important that to highlight that glaucoma can be totally asymptomatic. And it is important that people do go to see optician regularly, particularly in those with family history of glaucoma. Because if you have family history, your father, your uncle, your sister has glaucoma, your risk of glaucoma will be much higher than the average patient.
That's a little bit like cancer, right?
Well, cancer tend not to have a genetic predisposition, but cancer, you're right, can be asymptomatic, but they do tend to have symptoms or sign. You see, you can fear the problem with glaucoma or the optic nerve damage is that the damage is within the eye. You can't actually see them. Some cancer, skin cancer, you can see the damage on your skin. Obviously, lung cancer, you will see, then only develop it, only sort of seek help if you see a symptom, have started developing symptoms of coughing or symptoms of the cancer. And some are picked up coincidentally by scanning of your eye or x-ray for other condition. So yes, screening can pick up some cancer. And certainly there are screening programs for many cancers such as breast cancer, and Japan, where the gastric stomach cancer risk is high, they do screening for stomach cancer. And yes, you're right. Some of the cancer can be screened, do have screening program like colon cancer. We now in the UK have a screening program for patients above age of 50. So similarly, glaucoma should also have a screening program, but it's a self-driven one, particularly a patient who has family history of glaucoma, that you should see an optician regularly to make sure that you're screened for glaucoma above age of 40.
How often you should measure your eye pressure?
If you don't have glaucoma, having tests done once a year at the optician will be sufficient. You don't need it more than that. But if you have glaucoma and you're being treated, that will depend how high the pressure is, and your glaucoma specialist will be able to guide you what is a safe interval to test your pressure. They maybe have to be done every few months.
When do you decide that the glaucoma has to be operated instead of putting drops?
Yes, that's a very good question. Early on, I was talking about majority of patients. In fact, every patient with glaucoma can be treated by drops, medication, or a simple laser treatment, which is not hardly any side effect at all, called SLT laser. Beyond that, if patients still have very high pressure, which is too high for the optic nerve, continuously causing blindness, that is because of two things. One is the medication stop working, because you take same medication after a while, it just becomes less and less effective with time. Or as the aging changes, your eye become more damaged, the drainage pathway become not working, so your pressure keep going up and up and up. At that point, you will need glaucoma surgery. In general, about 20 to 30% of patients with glaucoma eventually will need some kind of glaucoma surgery in their lifetime.
And what is the difference between the glaucoma surgery and the cataract surgery?
So cataract surgery is to replace the natural lens with a plastic. Glaucoma surgeon is a plumber. Essentially, it's a plumber. So what you're doing is trying to drain the fluid out of the eye by putting a small tube or making a small hole in the eye to drain the fluid out of the eye, to create a safe level of pressure. Essentially, as I say, a plumbing job. You are trying to drain the excess fluid out of the eye to keep the pressure low. So it's a much more tricky procedure, and the risk of complication is much, much higher than a standard cataract operation. And the length of time of surgery is greater. It could take up to an hour or even an hour and a half in the complex cases. And because of the risk is greater, we don't really advise patients to do surgery unless they have tried drops or simple laser and medication and it's still not working. Then at that point, we say we should consider glaucoma surgery.
So how many in percentage cataract operation is safe and gives no complications? On what percentage? 90%?
More than 90%. Cataract surgery is highly predictable.
What about glaucoma?
Glaucoma patient will have 10% will have some kind of complication. In
10%.
cataract, 10% will have some sort of complication. Most of them are okay.
And how do you cure the complications? I mean,
it all depends what the complication is. In glaucoma operation can have complications such as, usually it's the pressure becoming too low and causes other complication. Because if you think about a balloon, if you deflate it too much, it collapses. So the eye have the same problem. If you suddenly drain too much fluid out of the eye can collapse and there can be bleeding inside the eye. So that's called hypotony or low pressure and hemorrhage. Both of those can be devastating for the vision long term. They can go blind from that. But the complication that causes blindness is rare. Thankfully, it's rare. I mean, less than 1 in 100 will have this such serious complication. Majority of them are simple temporary problems such as a little bit of hemorrhage, which will go by themselves, or pressure slightly low, which you can just inject something into the eye to firm up the eye. It's like balloon. You slowly reinflate the balloon a little bit, and it stabilizes.
And how can you reach a stable condition once you are operated?
Yeah.
Then you are operated once and forever, or it comes back and back?
In the successful glaucoma operation, the eye reaches what we call a perfect equilibrium, where the fluid, the aqueous produced in the eye, nourish the eye, then drain out to the extra channel you created. And then it maintain a perfect pressure, which is safe for the glaucoma. And that can last forever. However, successful glaucoma surgery in some way is depending on the exit point of the aqueous. The exit point of aqueous out of the eye, it creates a little blister, a blister of human tissue or conjunctival tissue. It's almost form a little lake around the eye, or called bleb. And that allows the fluid to drain into it and then also slowly diffuse out of the eye. In which time this lake can become so resistant to fluid going through because of scarring and inflammation. And glaucoma surgery can fail even 5 years, 6 years, 10 years later because of the continuous inflammations of scarrings around the exit point of the aqueous. So it's not like cataract. Cataract surgery, once it's successful, after 3 months, it's almost guaranteed it is a successful rest of your life.
And how long is the recovery from those operations? And what do you suggest to do? I mean, what people have to do?
Well, cataract operation recovery is very quick. Few days, you're fully recovered and back to normal activity. Glaucoma operation, minimum 2 weeks, maximum 2, 3, or sometimes 4 to 6 weeks before the eye stabilizes. So it can very much be dependent on the recovery process or whether the patient encounter complication. Let's say in the 90% of the patient who did not have any complication, they usually have about first week or two of slightly blurry vision, and 4 to 6 weeks later, the eye pretty much back to normal.
You have to put a patch?
You put a patch on usually on the first day after the surgery, on the day one, but they don't have to do that after that.
So altogether, the eyes are a very delicate organ after a certain age, right? And probably people are very worried about getting blind, right? The idea of being blind. And so there is a lot of psychological fear in your patients before they are operated or when they know that they have this disease.
Absolutely. I think the fear of blindness, I think vision is probably one of the most intimate or important sensory organ that human being has. The thought of losing vision can be very anxiety inducing, as you say. Rightly so. Glaucoma damage, once it causes damage, is a irreversible process. So even if you have successful glaucoma surgery, it doesn't bring back the vision. So you actually want to do the glaucoma surgery before it causes blindness because you can't bring it back again. So this is why the psychological acceptance of having glaucoma surgery can be quite difficult for patients to accept that I'm doing a surgery. Unlike cataract surgery, when I do the surgery, you can see better. No, glaucoma surgery, I can do the surgery for you. You're not going to see better. At most, you're going to see as well as what you have before. And then what happened is that there is the risk that comes with it of complication and losing sight. But this is a long-term thing. So the idea of doing glaucoma surgery is not that we're going to improve your vision. It's to trying to save you from going blind in 5-10 years' time. So this is why we offer to do glaucoma surgery to our patient whose pressures are too high despite medication drops.
When we talk to doctors and scientists and researchers, many doctors we interviewed say that maybe or not in a very long time, the cancer will be cured. Some are already cured, others will be cured. Instead, there are other diseases like dementia or like Parkinson and so on and so forth, who are more difficult to cure. Do you think that the ultimate goal, is it a dream, a possibility, that the ultimate goal would be to cure blindness? To be blind is like being dead. I mean, the eyes are dead.
Absolutely. So
is it a dream, the idea that you may change this and eventually cure the blindness, you know?
That's an extremely important question, and also require a bit of explanation regarding the types of condition, the types of cells that glaucoma damage. Now, in our body, there are different types of cells. Some of them, like muscle cells, for example, if you damage muscles, they regrow, they remodel, they regrow, they regenerate. Tissue or cells in the nervous system, brain, and the eye also is part of the brain nervous system. Those cells, once they die, they don't actually regenerate very well. So they don't regrow very well. So this is why the treating or curing blindness from glaucoma is super difficult, because you have a cells that doesn't regrow. So it's not like taking away the cancer of the legs, whatever, and you don't need those extra mass or muscles or whatever, but also some of the tissue, they will regrow and replace the cells that was lost by removing from the cancer-infected cells. So this is why treating and regaining or curing glaucoma is a much, much more difficult process. Now, I like to believe that eventually we have a way of treating glaucoma by somehow regenerating the neurons or new cells that gives you vision. But I think this will be much more difficult than.
But why, Professor? Why nowadays you can replace the heart, you can replace the liver and many other organs, and why can't you replace the eyes? I mean,
it's a no.
If you get blind, why can't you put new eyes in?
It's because it's the neuron cells rather than muscle cells. It's partly to do with regeneration. They don't regrow. So if you attach a piece of muscle to then and your another muscle, they just grow and then connect each other, blood vessels as well. But if you kind of connect two nerve tissue or neuron cells outside new one versus your own one, they don't glue together. They don't grow anywhere.
Why?
It's just the way the cells are. They're programmed not to grow. We don't know why. Maybe in some way, if you think about it, your brain has a skull, which is a fixed space. So when you have a fixed space, you may not want the cells inside your brain to regrow and regenerate very easily. Because if you do, your brain is fixed in that skull. Anyway, it will, I won't say explode, but it will certainly kill you if it grows too easily, right? So neuron cells have, by evolution or whatever reason, and the built and the existence of the skull to prevent damage to neuron cells, which are very, very delicate, also programmed in such a way it doesn't regrow easily. Otherwise, you would have people die from regrow or regenerations of neurological cells within the brain. So that is a very specific neurons from the nervous system that they don't regrow. And this is why connections or trying to do a transplant, very, very difficult.
the world is evolving very fast, and now there is this big discussion, big change, which is the artificial intelligence, right?
Yeah.
And we don't know where the technology and science will go. There may be other changes. Do you think that it could be possible to invent a kind of virtual way of seeing, that you are blind, but
Yeah.
nevertheless,
Yeah.
through something else,
Yeah.
you have the feeling that you see?
Of course. At the end of the day, images are generated within the brain from the stimulation from the neuron signal coming into your brain. Yes, there has been attempt, or there are devices in the available at the moment where it captures signal, it implant it into your eye, where you capture the light signal and then turn it into an electrical signal, and the implant then stimulate the occipital part of your brain to mimic image. Now, those images, unfortunately, at this moment in time, are very crude. So in some way, it just gives you sensation of something moving in front of your eye. Somebody who is completely blind, you can see a shadow, you can see something moving in front of your eye. Maybe some people even say they can see shape in front of the eye based on the signal being transmitted by the receptor implanted in the eye and sending the signal to your brain. So at this moment in time, those definitions are not there to replace vision. In order to replace vision fully, you can see how much more intricate in terms of stimulation on your brain. It will have to be a very small area, multiple area of being stimulated by the signal generated in the eye. So that's very difficult. So I think it is possible eventually, but it's going to take a while for that artificial generations of light signal into your image, into your brain that you can perceive to a degree that gives you even 40-50% of what human can see. At the moment, it's a very minimal shadow of image that you can generate, not the clarity that will make a difference to you and I.
But we talk about glaucoma and the fact that glaucoma is one of the most important vehicles, let's say, to blindness. But let me ask you a question, which I hope it doesn't sound morbid, but since the old days, since ever, there are people who sadly are born blind. They are blind from the beginning. The people who unfortunately have this illness, do they develop cataract, glaucoma, or infection, or whatever? Is an ophthalmologist curing also blind people?
Yeah,
because you still have the eyes, right?
That's right. Yeah. If you're born blind, and they usually a catastrophic thing happen in the embryonic stage before you're born, and usually it's like the optic nerve did not grow properly, so a patient really couldn't see out of the eye at all. Yes, in those patients, if you just have the optic nerve damage, you can still develop cataract and glaucoma or high pressure in the eye. But whether to treat those or not, it becomes academic, because if you cannot see, if you do not have the ability to send signal from your eye to your brain and allow you to see, it doesn't matter if you replace the lens or treat the glaucoma, it still wouldn't change anything. So you haven't treated the cause, which is the optic nerve. But there are people who are blind when they're born because of cataract, for example. Baby, they're born with cataract, they can't see from that. Yes, then you can be operated on to remove the cataract and replace it with, well, controversial whether to, in a young baby, you replace it with a plastic lens or not. So depends on the causes why patient or children born or baby are born blind. Some of those can be treated. Some of them won't be able to. We do not have any effective treatment for that.
And is it true that people who are blind, who are always blind, they develop a special sensitivity with touching, with, that they have other ways? To be blind is certainly an illness, or something not good. It's like to be without a leg. But most people who are blind have a great lives. They can become singers, they can become writers, they can have a real life.
Yeah, it's interesting, isn't it? I guess, well, I mean, it's a philosophical or not, but I've always think about this, whether if you're born blind, you probably learn that idea of your environment and using touch and smells and all the other thing and not using visual clue, and you probably will adapt to it quicker. But if you are born seeing, then gradually become blind and losing your visual cue, I think it's become much more difficult, I think, for patients. But at the same token, if you lose your sight when you're young, and I'm sure all your other sensory organ will become slightly more tuned up to compensate for the lack of vision. I mean, to some extent, we do see them anyway, because it's about, not just that, it's about what we call experience or things. So, for example, if you lose sight in one eye, you have only one eye, so you will not be able to judge distance very well. You lost that sense of depth because everything is two-dimensional, not three-dimensional. So, for example, when you put a coffee onto a table, you were likely to miss the edge of the table and you can drop it down onto the floor. But patients who are born with one eye only, they learn to use other visual cue, like shadow or any other thing, to judge distance. So they don't need to have three-dimensional vision to judge distance. So they're much better at that. So I have no doubt we all adapt to our own limitation, our physical limitation. So yes, if you lose your vision, I'm sure your other sensory system will become much more developed or upgraded to compensate for that. So yeah, there is an element for that.
For a scientist, an ophthalmologist, a person like you, of course, you are also a surgeon. And is your ultimate goal the hope that one day people will not be blind?
100%. I mean, as a glaucoma specialist or professor in glaucoma research, my aim has been and always be trying to find cure for glaucoma. The question is whether I can achieve it in my professional lifetime. And I'm pessimistic, but I'm also encouraged by the development that's ongoing at the moment in terms of generations of new glaucoma surgery coming through. Some of them are proving to be very, very much more effective than the old surgery now that we're seeing. So those are encouraging, but the surgery or the new implant are still not without risk of complication. So it'd be nice to have a surgery where glaucoma surgery is just as successful as a cataract operation, for example.
And who is improving these techniques?
Multiple people, small companies, startup, coming up with new ideas, coming up with a new implant and trying it out on animal first, usually, then in human, in a small study. And then I usually get involved in quite early stages of this kind of implant and trying to make sure that it works in our population and get it approved for general use. So yes, I'm involved in pretty much with the small, usually there's quite a small company, startup with a new implant, and they come to me with the project proposal to try the implant on patient with glaucoma.
And where do you do your experiments? You do them on animals?
Well, I don't do animal experiments anymore. I used to, but I now deal with glaucoma implant beyond that stage when they are ready to be implanted in human.
And how is the state of ophthalmology? I mean, are there countries like China, United States, where they are more advanced, or it's the same everywhere?
Yeah. I think there are some subtle differences in terms of glaucoma quality services all over the world. But I mean, not speaking about third world, where like Africa, where they are very generally very low GDP, will not be able to afford a lot of the things that we take it for granted in the UK or in the US or in China. Most of those developing country or developed country, in terms of the skill set, are very similar The only difference is availability of some of the devices or implant that we use to treat glaucoma. Some countries have them, some countries don't because of the regulatory process. It can take longer. So that varies. So a strange thing, actually, because this is where the divergence started becoming quite apparent now, that in the UK and Europe in general, we actually have more choices of glaucoma devices for patient and drops for patient in general than the US. US are quite limiting, in part because the FDA in the US has been quite stringent regarding their approval process for new glaucoma surgery or glaucoma medication. So in a strange way, that in the UK and Europe, we actually able to offer our patient more choice of surgery, in my view, better suited for the patient than they have in America.
It's strange because they normally, I mean, I'm sorry to say this, but especially lately, there is a lot of criticism about UK medicine, and I don't know if I am right or wrong, and the same is in Europe, that let's say you have an Indian doctor or Chinese doctor or an African doctor who comes to work here, they need less examination that they do if they go to work in the United States. In the United States, they have to have a process to start all over again, to be approved, to become a regular doctors or professors. Is it true or not?
Actually, no. Actually, it's very similar now. In the UK, US, same thing likewise, attract a lot of overseas doctor. So I myself was one of those who spent a year there, but I was there for a specific aim just to learn about a particular type of glaucoma research. But you have to do exam in the US to prove, and then you have to do residency to get your license to practice as a specialist. And in the UK, it's the same. The only time, interestingly, that this kind of requirement become less so is when we were part of the EU, that European trained doctors are considered equivalent. So doctors who are trained in Italy or Spain or everywhere in Europe, when they become a specialist, ophthalmologist, they have a license to practice in the UK as well, because that's part of the EU. We can't discriminate against them. Now, since Brexit, that's all gone. So European doctors are treated like doctors from any other country now. So they have to pass the language exam, have a minimum score in those, and B, they have to pass a exam that will accredit or recognize their qualification. Then they have to do the training or shows training they have done in their home country that is equivalent in terms of quality and quantity to a UK training, and only then they become a specialist. So it's not as easy as it seems, actually. So I think that the process of accrediting doctors in the UK is very good. I think it's very good.
Now, I'm sorry to ask this question, you can answer or not. You know, there's a lot of talking nowadays about racism, and the word race is something that we cannot use. It's totally incorrect, and so on and so forth. But I mean, without any personal thing, to be a Chinese or to be a black man for Africa or to be an Indian or to be a French person or an English person, it's different, right? We're different type of people. Do we all have the same eyes? You said that the Japanese are more careful about the intestinal research, right?
Yeah. So, for example, Japanese patients tend to population have a higher risk of stomach cancer. So they have a screening for stomach cancer for 40, 50 years. But in the UK and Europe, the risk is lower. So there's no cost benefit of screening patients for stomach cancer routinely. Now, the race is important. Some of it may be race related. Some of them may be the environment they are in. The dietary component may explain some of the reason why certain cancers are more common in some populations, in some environment. But when you started talking about race, it's so fascinating. Race in glaucoma is one of the biggest interests of my research, or my biggest research interest, partly because of West African populations or Afro-Caribbean population, which form about 50% of my patient population in South London, where I'm a consultant. Black patient or patients of African origin have 4 times higher risk of developing glaucoma than an equivalent European population. That's huge. We're talking about a 40-year-old, instead of 1% risk of glaucoma, there are 4 to 5% risk of glaucoma. So much greater. On top of that, when you do glaucoma surgery on blood patients, they tend to fail because they have very aggressive healing process called keloid formations in the skin, but scarring in the eye, and then stop the glaucoma surgery from working. And that risk is much greater than a European Caucasian population patient, for example. So in black patient, race is critical in terms of type of glaucoma they have, which is open angle, similar to most of the European population. They have a younger age, before 40 in a lot of them, and they are greater in terms of the risk, about 4 times greater than the white Caucasian population. And when you come to do surgery, they are probably or nearly twice as likely to fail because of their race. So that's a big thing. Now, then you have the East Asian population, like Chinese and Mongolian and Burmese and things like that. They tend to have a greater risk of what different type of glaucoma called close angle or angle closure glaucoma, while Europeans tend to have an open angle glaucoma. That is just a subtype of glaucoma. So yes, race is very important in terms of gives you the risk of different population and what type of glaucoma and how much greater their risk of develop glaucoma. And also, depending on the type of glaucoma, your treatment may be different for those patients, depending on their
So a
race.
doctor like you who operates in a city where there are lots of different people living together, people from different races, live in big cities like London, you have much bigger experience than a doctor who will operate in cities where there are much less multi-ethnical people, right? Because you're used to see all kind of patients, or like in New York is the same, or in big cities. So probably is not only the quality of the training and of the doctor, but also the use to see many different kind of people. That
Yes.
you wouldn't see if you were a doctor in central France, in a smaller city, right? Or in central Germany.
Absolutely. I think living and practicing in London does no doubt expose me to a multicultural population from different country. And the glaucoma can be much more difficult to treat, particularly among the Afro-Caribbean patient that we see. So I always tell my colleagues in meeting who look after, for example, populations of mostly 99% white Caucasian population in central Germany, is that their glaucoma surgery population is very, very different from mine. They may not have as much failure from their surgery. They might have much lower rate of complication, not because they are a better surgeon or I'm the worst, but I'm not as good as they are surgically. It's just because my populations with this kind of difficult glaucoma do tend to have higher risk of failure and higher risk complication. Yes, absolutely. And we are renowned for that in our center at St. Thomas's, because we look after very difficult population with very difficult glaucoma. And this is why we attract fellows or trainees from all over the world to come to train with us to learn about how to manage glaucoma. Because glaucoma is not about learning to treat the easy cases, which is, of course, 90% of the time, even if you live in a population where mostly Caucasian white population, you will come across difficult glaucoma, complicated glaucoma. As a professional, as a highly specialized glaucoma specialist, you should be able to learn to look after those difficult cases as well. And this is why doctors come to us in our unit to learn those difficult cases.
I know it might sound a silly question, my last question. How do you feel when you have failure?
It's devastating. And that's number one. It's absolutely devastating. When you have failure, that causes blinding complication as well.
And failure is not only due to your incompetence, right? It's because it's not due to that.
It's not due to that, but of course it can be. We're human after all. We make mistake, right? We are human. I mean, surgeon has to constantly live with the consequences of their action. It could be a small slip or small momentary loss of concentration that you did not see some tissue coming in front of you, or it could be simply the eyes is too complicated. Despite your best technique, your best effort, patient develop blinding condition. That happened. It can be either. And so
it happened many times to you.
I hope not, but it happened. It happened. It's not very tough, but it's a very difficult one. And this is why when a glaucoma surgeon, as they get older, the first thing they give up is glaucoma surgery because
it's very delicate and
not very forgiving. If you have a complication, is devastating and it can cause blindness. So,
and glaucoma is something that because of the climate, because of the environment, because of the pollution, because of the light, whatever, because of the computer, because of the television, the use of television and computer, is it a disease that is increasing or not? I'm sorry to compare, for instance, in the cancer, the sorrow, the preoccupation of most oncologists is not that they are not improving their techniques or their medicine or the way of treating, but is that the fact that young people, many more young people have cancer, and this is something new in a way, and they don't exactly know the cause of it.
Yeah, the environmental factors for glaucoma is probably there, but it's probably not as big an influence as something like cancer. It's just one of those diseases where the age and the genetic and the age and genetic actually much more important than environmental. But don't get me wrong, there will be some environmental factor, potentially UV light or pollution may increase the risk of glaucoma, but those evidence are not very, very strong.
If you expose too much yourself to the sun, which is very bad for the skin, for instance, is it bad for the eyes?
Yeah, well, certainly UV light can cause conditions like cataract and other conditions like pterygium. But in terms of direct link to glaucoma, there isn't there. I'm not saying that there wouldn't be. Possibly in the future we might find there's a link to it, but at the moment there's no link between sunlight exposure and glaucoma development.
And is there any prevention that can be done? I mean, they say drink green tea or do this kind of thing.
Nothing proven yet. There's nothing that has been studied suggests that any kind of supplement or exercise or anything that can proven to lessen the risk of glaucoma, unfortunately. So it is a condition that can cause you blindness without you realizing it. So it is, in a final word, I want to say it's very important for people who are at risk of developing glaucoma, either they are getting older or they have a family disease or the condition, or they are Black or Afro-Caribbean, they must go to see an optician regularly every year to make sure that these conditions are picked up before the damage has occurred. Because once the damage is done, it's irreversible, largely. So you cannot bring it back. So it's important.
Can I ask, is there something that is unique about the human eye? There are many different kinds of eye, insect eyes, different animals' eyes, so on and so forth. You've worked with animal eyes as well. What is it that you have found that is unique about the human eye?
I mean, obviously, the human eye is unlike some other animals who doesn't have three-dimensional. We two eyes seeing forward, and we have a three-dimensional vision all the time. And the clarity, the detail of the vision that we get in human eye is much greater than a lot of animals. Well, of course, eagle. We know that eagle has incredible sensitivity in the macula. They can see small target miles away. But so beyond the certain well-developed eyes in animal kingdom, I think our eyes is complex in the sense that they offer three-dimensional vision, and they gives you that color, they gives you that clarity and detailed vision that a lot of animals do not have. Beyond that, some other things are harder to know, but some animals do have unique things like multiple lids and things like that, but that's for presumably because of the nature where the environment they're in, they need to protect their eye a bit more. But yeah, I think human eyes are unique in that sense that it gives you the much more detailed vision and three-dimensionality.
Professor Lim, thank you very much for this long conversation.
Alain Elkann interviews.